So I'm so excited to have both Drs. Reddy and Dr. Larson joining me today. And I think this is going to be a very exciting and very informative discussion. Let's start about this very popular topic, heart rate variability. What does it mean, and how do we use it? Let me start with you, Dr. Larson. What does heart rate variability mean for you?
Heart rate variability really evolved as a physiologic measuring tool to try and investigate the balance between the various components of the nervous system predominantly on heart rate, but also on kind of all of cardiovascular control. And heart rate variability often was really just performed in the laboratory setting in physiology studies to look at things like sudden cardiac death risk or metabolic syndrome and some heart arrhythmias. But really now that we have wearables has evolved because essentially the only input data you need to kind of begin to calculate heart rate variability is just a heart rate. It basically uses information about the R to R interval and then evaluating different time and frequency domains to actually make some inferences about the relative balance between things like the sympathetic and the parasympathetic nervous system on the heart rate and on cardiovascular function. And so it's a very simple concept. You're just kind of detecting different oscillations in the R to R interval, but you can actually get pretty sophisticated in making different measurements and inferring different things about the input of sympathetic tone, parasympathetic tone, the balance between the two. You can do so predominantly at rest, but there's also people looking at the influence during exercise and after exercise.
So just to kind of clarify certain things, when you talk about RR intervals, it's the ECG, electrocardiogram tracing, and you're just measuring the number of heartbeats using the RR interval.
Yeah, exactly. Yep. So historically we would just take a continuous electrocardiogram tracing, and then we would have that as a long kind of display. You can have basically a long continuous run of data, and then you're looking at the difference in the timing between the peaks between different components of that electrical signal. And those peaks, the R waves, basically correspond to a heartbeat, right? A pulse as you would feel it. So historically they used ECG, but nowadays when you have things like some of the Apple Watches or smartwatches, you can also simply use information about the heart rate. So you can get rather kind of granular with the details of the ECG, or you can keep it rather simple if the device is able to detect your heart rate and the difference between your pulse from second to second. It's basically doing the same thing.
Perfect. So, Dr. Reddy, what would be defined as a good heart rate variability? If I'm wearing an Apple Watch and I look at the tracing, how would I say, hey, I'm good, or oh my God, I'm really bad? How does it look?
Yeah, that's a great question. So generally, we don't compare between individuals. When you check heart rate variability, you have to compare it to yourself. So you try and get a standard for yourself, and on a certain morning when you wake up, generally people check their HRVs in the morning. They check it against their average, their running average. And if it's higher than usual, that's a good sign. That's showing that they're having a lot of variability. And so their vagal tone is probably a little bit higher that day. And so we use HRV to, as Dr. Larson was mentioning, we use it to estimate how the balance is between parasympathetic and sympathetic. And so if the HRV is high one day, that means that you may be well rested and your vagal tone is a little bit higher. So we don't generally say this is a good number, this is a bad number. We just kind of compare it to the same average for that person.
So obviously, if you're not comparing, then comparing it with any individual, how do you quantify it? Like it seems like a very subjective kind of a process, right? So how explain a report if you have to see of a patient, and if you have to comment on that.
Yeah, so the way it works is generally it doesn't tell you your HRV on day one. It gathers some information, gets some baseline information as to what your normal is, and then on subsequent measurements, it'll compare it to the baseline. And so it'll say HRV of 100 milliseconds or 120 milliseconds. And there has to be some adjustment to age as well. We think that younger folks tend to have higher HRVs, and as people get older, the HRV can shift downwards. And you just being a cardiologist, you probably have seen that when we do EKGs on younger folks, we tend to see sinus arrhythmia a little bit more,
Yes.
which is variable R to R intervals. And so that's basically the same concept where HRV may be a little bit higher with younger folks, athletic folks.
So, Dr. Larson,
I was just going to say too, I think Dr. Reddy pointed out a really important thing is that it's really a relative kind of measurement, so relative to yourself. And the data that you're going to get on, let's say, a smartwatch or a wearable piece of data, I think this kind of highlights one of the important parts of us trying to interpret some wearable data, right? Is that in some ways that's a little bit of a black box to know exactly how Apple or Garmin or whomever the company might be is calculating HRV. And there's actually a lot of ways to do it. I mean, in the scientific literature, there's many kind of complicated time domains and frequency domains. And so the report that you might get on your watch is probably going to look a little bit different than how we might think about it in a research setting. And I think we think there's probably good correlation, but that's always, I think, something you have to take with a grain of salt.
So let's say you have a patient who's had a heart attack, okay, and is coming to your lab, okay, and you want to measure how well this patient is doing. So you want to have a wide range of heart rate variability, or you want a narrow range? Like, how do you navigate that? Either of you.
Yeah, I would say big picture wise, more is better in terms of heart rate variability, but that's kind of an oversimplification of the concept. So there's different kind of components to heart rate variability that tell us a little bit more, let's say, about the sympathetic nervous system or about the parasympathetic nervous system. And so we're trying to interpret those as a balance between the two. Kind of when it gets simplified and down to a piece of device wearable data, in general, more is generally better, or more vagal components are generally better, right? We like to see kind of more input from vagal tone at rest. And you can think about that very basically to say, like, at rest, your sympathetic nervous system is nice and calm and you're kind of in a good balance between the two. But that's also kind of an oversimplification because there's also measures that would measure sympathetic activity. So it's all about the balance between the two. But I guess, in Dr. Reddy's kind of nice summary too, when you think about it relative to yourself, more variability is generally thought to be better. That's thought to represent more vagal input to the heart rate.
So just for the audience sake, sympathetic nervous system is your fight or flight response. It's your, whenever you get chased by a bull, that's your sympathetic system. And parasympathetic is the zen and calm, and that's the balance. So Dr. Reddy, back to you. How do I improve my heart rate variability? What are the things I can do?
So anything that would condition your heart to be more less responsive to inputs. So one of the best ways is to be physically active. When people are physically active, their vagal tone tends to improve. A very simple way of thinking about this is your body's so adjusted to working with catecholamines running through it that when you're at rest, it thinks that it's really, there's nothing going on and there's not a lot of input. And so physical activity is definitely a big part of it. Another thing, when people are being athletic and exercising regularly, giving yourself rest periods can also improve HRV. And in fact, that's one way that a lot of athletic people who are training or are part of a team, they track whether they should go hard on a certain workout, is if their HRV allows them to. Meaning, if their HRV is nice and high, that means they've gotten sufficient rest and their body has recovered, so they can go a little bit harder that day. If they wake up that morning and the HRV is a little bit on the lower side, then maybe they'll do more of a recovery run or something along those lines.
That's interesting. So I want to simplify it a little bit more. So let's say my heart rate is at 56 at baseline. Okay. And when I exercise, my heart rate should jump up to however fast I think, and then I come back down. And this measure is what we are calling as heart rate variability.
Not quite. So what you're describing is maybe more heart rate recovery, which is also a measurement of parasympathetic drive. Heart rate recovery is basically once you get your heart rate up to a max level, how quickly does it come back down to normal? And people who are athletic and fit, their heart rate will recover quite quickly. Generally, the minimum is about 10 beats per minute in the first minute. So if you get your heart rate up to 150 beats per minute, after you start to recover and stop your exercise, it should drop at least to 140, if not lower. And that's what you're kind of describing more. HRV is actually just beat to beat at rest. So the person wakes up in the morning, they check their rhythm over 10 seconds or whatever the algorithm is, and it's just beat to beat how many millisecond difference there is from one R to R interval or one beat to the next beat compared to the next segment. And so if the first beat to beat the first beat to beat interval is 400 milliseconds and the next one is 410 milliseconds, then the variability is 10 milliseconds there. So it's just beat to beat at rest is what HRV is.
So that's even more nuanced than I imagined. And so what did we do before the age of the smartwatches?
Yeah.
I mean, a lot of that just becomes kind of your kind of ratings of perceived exertion or kind of subjective measures of how you're feeling. I think Dr. Reddy pointed out a really important point, is that the thought is we maybe be able to use this HRV at rest to tell us something about kind of where the body is on the range of kind of, overtrained, optimally trained, undertrained on any given day or over any given time period. So historically, I mean, if we're going to talk about how do you judge that, it's really how are you feeling and kind of what the training schedule is. And then trying to balance out, intense days, less intense days, recovery days, resistance training, aerobic training. So HRV might be a tool to help us better optimize those schedules, to get a little bit more objective feedback just from the body at rest to know kind of what the body is ready to do on any given day.
So let's talk about things which affect the HRV. Obviously, sleep deprivation, that's a no-brainer. And obviously, alcohol intake the prior night or something like that. Does alcohol or the timing of food or timing of dinner, do all those things make a difference?
That's a really good question. I think, when we think about measuring it in the laboratory setting, we think there's a lot of things that influence it, right? We're actually pretty particular when we do kind of scientific measures of heart rate variability, that people are super still, that they breathe just at a steady rate, that there's no sound input, the temperature of the room is very particular. So when we do it in the research setting, we are like extremely particular about making sure we've kind of controlled all of the potential external forces that might influence someone's heart rate variability measures. So I think in that way, yes, all of those things could potentially influence heart rate variability. But I don't know that there's necessarily really robust data from wearables yet to say exactly how much. I'm sure it makes kind of physiologic sense that sleep would influence it, that alcohol would influence it. But I would say, when it comes to the wearables data, we're probably still trying to figure out how sensitive maybe some of those wearables data points are in terms of detecting, what's the influence of sleep? What's the influence of medications? What's the influence if you've recently been ill? We can kind of infer what would make sense physiologically from some of those, and that would certainly be reasonable to think about. But again, I think when it comes to the wearable, some of that stuff we just maybe don't know for sure.
So, Dr. Reddy, you touched upon this briefly. So if let's say my heart rate variability is high, okay, so that means I'm in a good place. So would that be the time I do aerobic or cardio workout? Is that the correlation?
Yeah, generally that's the thought, is basically a lot of athletes work out every single day and they choose their workout that day depending on how they're feeling, another kind of poor man's HRV is just resting heart rate. If your resting heart rate is at your expected level, that means you're probably rested. But if your resting heart rate's a little bit faster than you would expect, then maybe you're not so rested. And so when people are training for marathons or training for a sport, they're exercising every single day. And depending on their HRV on that morning, they'll choose the appropriate workout.
So that's interesting. So if my HRV is low, does that mean I need a rest day? Or does that mean what is the implication of that?
It's ultimately up to the individual, but this is just a data point to help them make that decision. But I will say there have been some clinical cases of mine. There's one particular woman who is around 52 years old, and she was training for a marathon. Her goal was to qualify for the Boston Marathon. And so she hired a trainer, and the trainer that she hired was having her work out every single day and restrict her calories to 1,800 calories a day, and at the same time do weightlifting and run 10 plus miles a day. And she ended up basically going into what we call overtrained or overtraining syndrome, or relative energy deficiency of sport, REDS. And she's now 2 years after being diagnosed with this, and she uses HRV every morning. In fact, she uses 3 different HRV apps to kind of tell her where she is physiologically. And she really appreciates it because it's objective feedback. She doesn't have to kind of feel it out herself. And depending on that, if 2 out of the 3 apps tell her that she's in the green zone, then she'll go out for a short run and things like that. So there are some clinical benefits of using this.
So so this is a healthy person. They can use it to kind of guide their exercise regimen. But what if a post-MI person or a heart failure patient? How do they use the HRV? Dr. Larson, do you want to take this?
Yeah, I think that gets pretty tricky. I mean, we can infer that because it's kind of, again, within a single person measurement, that let's say if something changes, if someone has an MI, we would expect their heart rate variability to decline after an MI, or if someone has, worsening of their heart failure, we might expect their HRV to decline. But admittedly, I think, maybe the MI patient is one example. The heart failure patients certainly become so complex, and there's so many kind of moving parts there, and especially with medications. I think you maybe could try to infer some things about that. But admittedly, I think if a patient brought that information to me, I would say, okay, we're going to maybe use this just as one small piece of everything else and kind of the traditional ways that we might treat heart failure and look for signs of success or signs of impending trouble. Because I would worry that there would be so many different moving parts, especially in a heart failure patient. Post-MI, kind of similar, right? You might have, beta blockers on board or kind of differences in medications, but you can imagine where someone could even potentially think about using that sort of data in cardiac rehab to say, how does it look over time and what happens on any given session or what happens over the course of those 36 sessions. So that would be, I think, interesting, but I don't know that I would, as a cardiologist in a clinical practice, use that as kind of a major structural piece of my practice. And Dr. Reddy, I don't know if you feel differently, but that's how I would look at it. Yeah,
I don't think we're there yet in terms of using it for every patient. But interestingly, there was a study published out of Mayo Rochester. Bruce Johnson was a senior author, called HRV Detect. And it kind of was trying to see if we could use HRV in patients that may be risk for ischemia. And so what they did was they measured HRV for, I think, about 200 people that were going for stress tests, and they were in the low to intermediate risk category for ischemia. And what they found was that people that had low HRV tended to be associated with having positive stress tests. So the thought is that maybe it can be an early detector for ischemia. It was a small study, but it kind of opened the door for that discussion.
Interesting. But so now, how about beta blockers and calcium channel blockers? How do they affect the HRV? Is it still a logical expectation that it's accurate in the presence of these medications?
I actually don't know the answer to that. I think it would probably, so beta blockers block the catecholamines from affecting the receptors. So it doesn't generally affect your vagal tone directly. It just blocks your sympathetic activation. So I don't know if it actually affects it. If anything, it would make your HRV higher, meaning it would show as though it would be higher. Is that what your thoughts are, Kathryn?
Yeah, that's a good question. I don't know that I've ever gone back through the literature to look at specific drug effects. I'm sure there might be some small studies out there, but again, kind of hearkening back to the same point, I think if a patient brought that information to me and they were on some of those medications, I would probably, make the same inferences as Dr. Reddy just from a physiology perspective. But I think probably worth taking some of that into consideration when you're interpreting it. I similarly don't know the details of the literature specifically on, metoprolol or amlodipine on heart rate variability, but it's probably out there.
Yeah, sure. All right. Now let's move on to the question I was asking you guys before, which is the heart rate recovery. Because that is something we use very common in clinical practice. So what do you think is the impact of heart rate recovery in overall cardiac health of a patient? Dr. Larson, do you want to start?
Yeah, I think, the first thing that comes to mind for me as a clinician is probably the place I see it the most is in our cardiopulmonary exercise test reports, right? So patients who come in for an exercise test, and actually really any sort of exercise test, that's often a data point that's kind of front and center in the reporting, because it's a helpful measure for me to get a sense of, how well, how fit, how kind of balanced a patient might be in terms of their cardiovascular exercise capacity or their cardiovascular function. So that's where it comes up the most for me. And I would say, if I'm looking through a report and the heart rate recovery is something that flags as abnormal, I guess to me that's something where, even if I'm looking for the test for different reasons, I might kind of make note of that with a patient and say that, gosh, there's some evidence here that kind of maybe we're not optimizing exercise capacity, or maybe there's something else going on that we're altering someone's physiologic responses to exercise. So it's an important kind of piece of the puzzle, but I don't know that I necessarily use it, let's say, as a therapeutic target, but I would definitely say if it's something that flags as abnormal on a report, that's something I'm going to take into account when seeing the patient.
That's interesting. How about you, Dr. Reddy? I honestly thought heart rate recovery is a big piece, at least like from the ischemia. I'm an interventional cardiologist, so everything is centered around ischemia for me, or lack of blood flow to the heart itself. And so that's a big piece for us. If the heart rate recovery is really poor, or if they stay beyond 2 minutes, then I'm like, oh my God, this patient is not, either poor exercise capacity, or we haven't adequately maybe we should go and put stents in. How about you, Dr. Reddy? How do you view this piece of information?
I wouldn't necessarily use it just to make the decision for intervention versus not, but it is a good prognostic indicator. There have been studies that's similar to the HRV detect study that people who have poor heart rate recovery are at increased risk for cardiac events down the road. When people look at stress tests, I think most people just look for ischemia or not ischemia, but there's so much other information that Dr. Larson was kind of getting to with these exercise tests. And heart rate recovery is one of them. Their fitness level is another one. Are they showing signs of arrhythmias and things like that? It's not only if they're ischemic or not, but from a prognostic level, I put a lot of emphasis on their fitness level compared to what we would expect. So their percent predicted fitness level. And also, I look at other things like heart rate recovery just to kind of get a sense of where they are from a fitness level. And when we're prescribing exercise or coming up with an exercise plan, those type of indicators can be helpful, so that we can dial in the appropriate intensity for these different folks.
So I think, Dr. Reddy, you segued into the next topic, which I wanted to talk about, is exercise capacity, metabolic equivalence, and how does that relate to fitness level, longevity, and how would you interpret that?
Do you want to go ahead?
Go ahead.
So I would just say one of the most important prognostic indicators for longevity is a person's fitness level. And in particular, peak VO2 or VO2 max has been studied in numerous studies, and has been shown to be people who tend to have higher VO2s or higher metabolic equivalents. They tend to live longer, healthier lives. And
I'm going to ask you to explain. I'm going to ask you to explain VO2 max a little bit more in layman's terms, so that the audience understands it.
So VO2 max is a measurement of how much oxygen is being used by the body, and more particularly the muscles. And when people are exercising, depending on the intensity that they're exercising, they're using a certain amount of oxygen. And if they're able to exercise to a very high intensity, then that volume of oxygen consumption is going to be higher. So it's essentially a way of measuring fitness level. and more particularly aerobic fitness level. So people that are cross-country runners or cross-country skiers or who are doing swimming, things like that, long-distance swimming, they tend to have better VO2s.
So, Dr. Larson, let's go talk about the prognostic indication, right? So, yes, normally people don't kind of measure their VO2 max. They just, walk on the treadmill. Or how can a person get a guesstimate of where they are?
Yeah, no, it's a great question. So you're right in that VO2 or kind of treadmill testing, right? Those are things often done in the clinical setting. So we might not be doing them necessarily at a population level or a screening level, albeit oftentimes some sort of exercise testing may be part of someone's kind of basic evaluation. So the data really comes from clinical exercise testing, but I think you're pointing out an important differentiation is that many patients aren't going to come to the lab and have a VO2 measured. And so on a day-to-day basis, I would say, before the wearables era, oftentimes it's a question of time and ratings of kind of perceived exertion that are going to tell you a little bit about what I might expect your fitness level is. So, simple things, kind of what sort of exercise are you doing? Is it walking around the house folding laundry, or is it playing singles tennis? Is it playing doubles tennis? For how many hours per week? And kind of what does that cumulatively look like? And we can actually do some pretty reasonable estimations of what your exercise capacity and what your level of fitness is if we can just take kind of a careful exercise history from you. And actually, we can get probably a good proportion of the way there just based on your history and kind of what you do. That also would take into account things like your age, if you're a male or a female, those sorts of things come into that equation too. But then if you really want to get down into the granular detail, you're going to maybe need a little bit more training information. But nowadays, you've also got the wearable data, many of which will actually come up with an estimated VO2. And I've kind of had mixed results, but overall, I think positive kind of correlations. If I've got a patient who's come in and done a clinical VO2 test and they have a Garmin watch or an Apple Watch or some sort of wearable device, and it's going to tell them a VO2. For the most part, they seem to be pretty good in terms of estimating what your VO2 is. So that's another kind of piece of information that we've seen kind of explode onto the scene right in the past few years with wearables, which I think probably does a reasonable good job of estimating the same sort of thing we'd measure in a clinical test.
Fantastic. So, Dr. Reddy, I'm going to kind of pick up some of the things that Dr. Larson said. If I don't have a wearable, okay, and I want to see where I am, okay, just with the household tasks, this is really bad, I need to exercise more, or I can actually do this, and therefore maybe I'm in a good shape. Can you give examples?
Yeah, so one is by estimating your METs. If you go online and just type in METs estimation, that'll give you a sense of your fitness level. And generally, one MET correlates with about 3.5 mLs per kg per min of VO2. So if you're able to get 10 METs worth of exercise, then your VO2 would estimate to be about 35. That's rough, but that's generally how we think about these things. But one way that when we're doing risk stratification for surgery, we ask, are you able to climb one flight of stairs with a grocery bag in your hand? That generally equates to about 3 or 4 METs. And we kind of discuss the intensity that they're doing day to day. But you're also bringing up another point that I wanted to make was, just like with HRV, I try not to have my patients compare themselves to other people. If they're making progress year after year, I think that's more motivating and maybe a better metric, because genetically some people are just going to be more fit and are not going to be prone to orthopedic issues or whatever. So comparing yourself to other people with these situations gets a little sticky.
So if I'm on an exercise program, okay, and I'm trying to improve my VO2 max or my, how frequently should I be checking? Obviously, I don't want to be checking day to day. Is it 1 week to a week or 1 month? What is the standard time, both of you as sports cardiologists, like what is the time needed for the heart to actually make proper, sustainable change in mechanisms, which can reflect as this is a good sustained improvement? how do you measure it, or how frequently should you be measuring it? Dr. Larson.
Yeah, no, that's a good question. And I would say, and I'm going to piggyback off of Dr. Reddy's last point, is that for each patient, it's going to be different. And so I think it's important to kind of keep in mind what your goals are and compare maybe to yourself and not to some sort of general rule that would magically kind of apply to all patients. And so I guess it also kind of makes me think, oftentimes one of the questions I try to ask all of my patients who come in to see me in sports cardiology is, what's your goal, right? If your goal is to kind of optimize your fitness for longevity, then I would actually say, maybe it's important to recheck every few months if you were curious about it. But probably what's most important is not so much that the number moves, but that you're able to kind of find a sustainable exercise practice, right? So the goal there should maybe not be, does the number improve? It's, am I still doing what I'm, trying to do 6 months later, and I'm not injured and I don't hate it, and, I found something that's enjoyable to me? That would actually be way more important to me as a clinical cardiologist than seeing 5 points increase in your peak VO2. That may be scientifically interesting, but it's maybe not going to get you the success you're actually looking for. But that may be different than if you were someone who's coming in and says, actually, next year, I want to run X time in a marathon. So then maybe you are going to talk about, maybe this is something we want to kind of keep in mind as a data point as you're working through things, or if you're recovering from sort of a cardiac issue, or you have a cardiac issue that you're trying to train in the presence of, maybe that's a piece of information we'll try and use together. In those situations, in all honesty, maybe not any more frequent than every few months to, as a clinical cardiologist, once a year, honestly. Those are the kind of big scope and trends that I tend to look for. But, again, I'm not a personal trainer. And so if you're working with a personal trainer, maybe they would like to know some more granular data that's going to help you adjust your day-to-day or week-to-week exercise program. But that's kind of how I would approach it. I say, first and foremost, kind of what's the goal of the patient, and is peak VO2 really the best measure? It is a super powerful prognostic marker. I don't think anyone would argue with that, but there I think you have to ask, is that really the measure that I need to use for any individual patient and what their exercise goals are?
So, Dr. Reddy, I'm going to now ask you about VO2 max, and she talked about, Dr. Larson just said it's a phenomenal prognostic marker, right? So if it is a phenomenal prognostic marker, why are we not using it more? Why are we not using it in our cancer patients and our diabetic patients, and why are we not aggressive about this?
You bring up a great point, and I think it should be used, maybe not VO2 particularly, but just fitness level in general. In fact, the AHA put out a statement a few years ago saying that fitness level should be a vital sign. Just like we check heart rate and blood pressure, does blood pressure really matter, or does how they're moving about their day matter? And so fitness level, I have every one of my nurses, when they're rooming my patients, I ask them to at least get a sense of what their fitness levels are, physical activities are, so that I can, and we document that in our objective section, because it's so important. Just like we have this reliance on ejection fraction, and we talk about, 65% is better than 35%. But if the person who's 65% has HFpEF and is unable to climb a flight of stairs, who cares about the number? It's more their fitness, it's their functional capacity that's important.
Absolutely true. Like I just yesterday met a 55-year-old patient with the ejection fraction less than 20%. I don't know how. I'm like, when I was prepping for his visit, I was like, how is this person even not in a hospital, etc. But this guy was absolutely fit, can do all, is completely compensated. So, and I'm sure if we put him on a CPET or something, we'll get a VO2 max, which is much, much higher than a person whose EF is normal and, but who's not fit. And it's really unfortunate. They use the frailty scale for doing surgical valves or TAVR replacements, etc., but we don't use it in other aspects of our medical practice, and we don't talk about it enough. And I think that's one of the reasons I wanted to bring this up, as people keep talking about heart rate variability and VO2 max, and maybe you train according to your heart rate variability and improve your VO2 max, and use that as you said, data points to improve your VO2 max, which is one of the most important predictors of longevity. So now wearables. We've been talking about it. I'm sure, like me, you're also getting patients who are tracking everything in their wearables. And like my heart rates I'm just sitting and watching TV and my heart rate is like 110 or 120. And it's normal rhythm. It's not a rhythm problem. So how do we tell the patients and the people who are listening to this how to navigate the information overload or the clinically not significant information you may be getting from your wearables? Dr. Larson, I
Yeah.
see you very enthusiastic about this question.
Yeah, no, your initial kind of comment, I think we've all had the patient who comes in with a 3-ring binder of data, who's maybe an engineer themselves and loves to track all that stuff. And, as a cardiologist, sometimes that's fun. And sometimes you just think, gosh, this is a lot of information. And I'm not sure how this is going to be helpful for me and the patient. But there's a huge range, right? Every patient is different and everyone has a different device and they wear it for a different reason. So kind of like I ask patients, why is, exercise, or what are your goals for exercise? I find myself often, looking at a patient's wrist, and if they wear a watch or they have a certain device or they talk to me about a certain device, I'll say, well, why did you get it first and foremost? Because if it was something you wanted to use as a tool, we can approach it one way. If it was something you got, actually for no reason whatsoever, and this is someone incidentally noted data that we're now trying to put into the kind of clinical realm, how are we going to use that? And then there's patients too who come in and they bought it because they're concerned about something, right? They had a symptom or they were noticing something, and so they are trying to use it now as a patient, but use it themselves as a diagnostic tool. And so I think that's maybe the place that I often start. And then also, I think it's always important too to be conscientious of trying to parse out the difference between cause and effect. So much of that information is there all the time, and I think can be hard as a patient or as a provider to really differentiate. If my heart rate's 110 and I'm looking at my watch and I'm feeling really anxious about it, or I'm having kind of a sensation of a rapid heart rate, is that the cause or is that the effect? And trying to parse out those two can be really challenging. And I do often find myself, saying to patients, if I'm not really concerned, I don't see any kind of expert evidence of an arrhythmia or something wrong, do we really need that data, or is that data we can kind of set aside and try and get you to focus on maybe what's more important in the moment, which is the symptom you're having or the situation you're in? So trying to kind of pull those two apart has been a real challenge for me at times. I don't know, Dr. Reddy, if you've got any thoughts about that either, but that's a place where I often kind of sit down and start with patients.
Yeah, very well said. Yeah, very well said. I think that's absolutely true. Some people like that objective feedback and they use it to motivate themselves. But other people get a little obsessed with it and focus negatively on if it's bad. Similarly with blood pressure monitoring, I'm sure you have patients that check their blood pressure 6 times a day. And if one thing is abnormal, then they freak out. Those type of situations, more information is not necessarily always good. So I first commend the patients when they come in with all that information. It shows that they're engaged in their health and want to do better from a health perspective. But I also try and put things in perspective. We don't need to know day to day or hour to hour heart rate trends or blood pressure trends or step counts or whatever. It's over a longer period of time. Are you improving in terms of your walks? I try and tell people to just keep a sense of how they're doing with their different workouts. So if they go for a walk around their neighborhood, are you able, week after week, are you noticing that it's easier for you to do that? And those type of things I think are a lot more useful than is my resting heart rate going down or is my HRV getting better or whatever it is. So I try and keep it in context for people. That's what I would say.
So, fast heart rates is one thing, but the slow heart rates, that's been honestly a bane in my practice of late because patients are wearing these wearables, whether it's a ring or whatever, and going to sleep with it. And sometimes these rings are waking them up because they have just set a heart rate, to wake them up as a low heart rate. And I find that a little bit more difficult to manage because the fact that, oh my God, am I going to die in my sleep becomes the biggest concern for them. And how do you navigate it? Dr. Reddy, I'll start with you this time.
I I ask them how they feel when they wake up, but generally, you have to verify a lot of these things. So when the wearables on the wrist, they're using a technology called PPG, which all it is measuring red blood cells as they go by. And given the fact that they're on the wrist, they're further away from your heart. And so the pulse that's felt at the wrist may not be as strong, and you can often underread your heart rate, especially if you're having ectopy like PVCs or PACs. Those beats don't get picked up on the wrist watch. And so very commonly they'll come to me with a heart rate of 40, but if you do an EKG, it's showing PVCs intermittently or whatever it is. So I try and have that discussion with them to not be overly dependent or overly stressed by these things, and to verify with a cardiac monitor.
Etc. So, Dr. Larson, let's talk about generally how accurate are these wearables for rhythm detection? I know Apple came out with this new assessment, a new update, atrial fibrillation, etc. How reliable are these wearables in rhythm detection?
Yeah. For the most part, I would say in broad strokes, pretty good, but still got a long ways to go. I think common things are common, right? So AFib, you mentioned, probably the most common thing we're trying to kind of figure out with a patient if we think AFib is present or not. And really most of the wearables do a pretty good job, but I guess, in my experience in my clinical practice is that oftentimes, if it's AFib and it's pretty clear and the device does a good job detecting it, but there's a lot of those kind of indeterminate values that are coming in, and maybe it's just my perception, but I tend to see a lot of those, and those stress the patients out, and we kind of have to sit down and go through the tracings together. And oftentimes the tracing is just not of good quality, right? And so what it's detecting is a lot of just artifact or kind of waveform variation from movement or some sort of interference. So I think when it's truly there and it says it's there, kind of the specificity is probably pretty high. The sensitivity, I think, is a little bit harder to know, but it's nice when you do actually have the waveforms available to review with an expert, or you can send them to your physician on a patient online portal and say, take a look at this and tell me what you see. And, it's also a little hard because, as Dr. Reddy pointed out, they're not necessarily designed yet to be really good at detecting PVCs or PACs, or know how to kind of interpolate those into detecting a heart rate, or, how much that irregularity gets introduced. And maybe it's just going to say something's abnormal, but it's not going to really specify what. And I think that also becomes a question. I don't know how interested Apple is in becoming an FDA-regulated device, with all of the kind of super fancy sensitivities there. So I would agree with Dr. Reddy too. Oftentimes, if it's a question and we just can't quite sort out how good the detection is, I'm going to get a clinical monitoring device, and then I feel a lot more confident about interpreting that data. And I'd also say it's a field that's changing rapidly. I not infrequently now talk to my patients about using devices like the Cardia device. So it's like a little stick of gum. That's actually got more kind of, what's the word I'm looking for? More detection pads on it, right? So you can actually get more leads, just like a traditional ECG. You can get more electrical signals transmitted. And actually the data in those is pretty nice. And so when patients send me those, I often find that that's actually very usable and actionable data.
That's fantastic. So our practice is going to be changing. Our patients are also going to be changing with these wearables. So Dr. Reddy, I'll come to you. If someone has got someone's goal is, okay, I'm turning 40 today. I want to get better in life. I'm going to get myself a smartwatch, and I'm going to use the data from the smartwatch to exercise better or exercise appropriately. So what would you tell the person? What are the things they should be looking, and how should they adjust their routine on a day-to-day basis?
So these different wearable devices track different things. They, as a general term, we call them activity trackers, and they tell you your step count. They give you an estimation of how many calories you've burned and things like that. And I'll be honest, I actually just looked into this for a different presentation, and the error with step counts and calorie expenditure estimation is quite bad. It's quite high. But what it's useful for is just kind of general trends. So if someone one day does, and your watch says 5,000 steps, and the next day it says 7,000 steps, it's probably not exactly 5,000, 7,000, but it's definitely showing that you've done more. So it's useful in that sense. What I try and tell people is, and I try and get a sense of where they're coming from when I'm giving exercise counseling advice. If it's a person that's never exercised before and wants kind of more simple information, then I just tell them, just try and do 30 minutes most days of the week. And it can be even just walking. And for somebody who's been sedentary or been focusing more on their work or on their family, that's a good start. If they can get 30 minutes a day of just walking around their block with their kids or whatever, that's a great start. But if someone is already kind of being active but wants to be a little bit more in tune with their health or improve their health, then I try and be a little bit more granular. I try and tell them at least this many workouts you should consider doing higher intensity, this many workouts maybe consider doing lower intensity so that you recover. And we kind of go into that.
Okay. So, Dr. Larson, now I'm going to come to you. And actually, Dr. Reddy spoke about this, but I'm going to ask you this question about overtraining syndrome, right? How does that look like? And how would an athlete know, oh, just not mentally burnt out, but maybe I'm physically burnt out?
Yeah, that's a good question. It's a complicated kind of topic. And I would say it's probably oversimplifying to think there's kind of one key measure we're going to look for and detect it. It probably best describes kind of a culmination of a lot of different things, a lot of which involve the cardiovascular system, but a lot of them don't necessarily need to, right? So, Dr. Reddy also mentioned things like relative energy deficiency. I think all of that kind of fits into the potential concerns about overtraining, and maybe not capital overtraining, but the concept of just doing too much. And so I would say the backbone of that really starts with a good history, certainly getting a sense of what the patient has been doing, how their exercise regimen has changed. Dr. Reddy pointed out too things like caloric restriction or kind of restriction of other components that's not exercise, so whether it's sleep or other environmental exposures. But the idea is that basically overtraining is you're getting to the point where you are doing enough exercise or doing enough training such that the kind of benefit that you're getting out of it has basically diminished and gone away, right? You've kind of pushed yourself past the kind of healthy homeostasis, the healthy equilibrium, to the point where you're no longer seeing the gains from all of your input. And if anything, actually, you're maybe seeing some decline in your exercise capacity, whether that's necessarily peak VO2, but it could be a lot of different components, whether it's strength or, your time in a running event or whatever it may be. So that's kind of broad strokes what I think about with overtraining syndrome. You can certainly get into the different nitty-gritty components of it, but I would say that's the general concept I would think about.
So now if I'm wearing one of the biggest reasons for podcasts like this and other shows like this, people are very reluctant to come to a doctor.
Yeah.
Because it takes a lot of time, appointments are far off, etc. So if I'm wearing a smartwatch, Dr. Reddy, how can I diagnose RSE or overtraining? This is too much. Like what metrics would I be looking at on my smartwatch?
Yeah, so generally overtraining is a clinical diagnosis. There's no strict criteria. If you meet this or that, then you have overtraining. But generally, as we were talking about, HRV can be a detector. And if your HRV suddenly drops without explanation and you think that you've been training a lot, then that can be a sign that you're moving towards overtraining. Resting heart rate, if your resting heart rate's really high, and I can tell you in this particular individual who was clearly in overtraining syndrome, her heart rate wouldn't go up with exercise. She didn't have the proper inputs. The catecholamines to her heart weren't there. She had basically adrenal insufficiency of sorts, where she would go out for a run and her heart rates would remain in the 70s. And that was a very dramatic, and one of the first things that she saw was that she wasn't able to do the workouts that she was able to do previously. But yeah, so those different wearable metrics can be useful, but it's usually a clinical diagnosis. And as Dr. Larson said, you have to get a careful exercise history from the patient.
So we are kind of coming to the final moments of this podcast. So Dr. Larson, what would be a good things you look for when you're choosing a wearable or a smartwatch or something? What would be the different things? Oh, this is a good wearable device because of A, B, C, and D. What are those A, B, and C, and D for you?
Yeah. Let's see. First and foremost, I think for a patient or, a non-patient who's going to go out and try and exercise and is curious if that data is going to be helpful to them, I think my first piece of advice is there's lots of ways to succeed. So there's lots of ways to be fit. There's lots of ways to exercise and do really well that don't always need to have that input. So I guess my first question would be to the patient, is that sort of information actually going to be helpful for you? Is it going to be distracting, or is it going to be potentially kind of anxiety provoking? Because there's plenty of people who, have been excellent runners, Olympic level athletes who've gotten to an extreme peak of performance and peak of fitness without that data before. So it's not a mandatory component. I guess my next question would be kind of, what sort of information are you comfortable with? Because some of these devices will give you a lot and have a lot of bells and whistles. And if it's someone who's maybe not super tech savvy or not super comfortable with knowing all that granular detail, focusing on a more simple device, maybe just a basic chest strap heart rate monitor for you to use when you go out for a run, keep it really nice and simple and know that you're not necessarily missing out on some big critical piece of data if you need to keep it simple. And then really, I guess the other questions would be, what sort of exercise are you interested in? If you want to swim and you're going to be in water, that's certainly going to be something you're going to have to think carefully about. If you're a runner, are you going to be someone who's running in a kind of urban area? Are you someone who's going to be running maybe out and doing some trail running? Is the GPS component of it important to you? And then what does your medical history look like? Are you someone who's, a 60-year-old male and recently you've been worried about AFib because you've been having some palpitations? What sort of devices are actually maybe better geared for you to use in terms of detecting AFib? Is it something you want to wear all the time? Or is it something you just want to have on hand to use as needed? All of those, I think, are important questions. And there's obviously a huge wealth of devices out there. So there's a lot of kind of sorting through. But those are, I think, maybe the points that I would start with if a patient was going to ask me a question of kind of what should I look for? What sort of devices should I ask for?
Fantastic. So, Dr. Reddy, final question to you. We are in the era of artificial intelligence. Okay. So if you have to, I'm sure you're looking into different variables which are going to predict things. So do you think we are going to get to a point with the wearable devices and artificial? What is that marriage between these two technologies going to look like in the future?
I think we're already starting to see that. With Apple, they have so much data. They have millions and millions of user data. And now they're pairing with different hospital systems to kind of see how that relates to clinical outcomes or clinical events. And I think it'll be very useful to try and see, just like HRV Detect was able to detect ischemia a little bit better and those at risk. Maybe there's certain characteristics, resting heart rate and peak heart rate and HRV and all of these things that can say that, oh, this person is at risk for a heart attack, or this person may be having signs of COVID. Now these wearables have temperature tracking as well. And so there's so much information there. And hopefully AI is able to kind of parse through that. And that's a big space that Google's involved with, Amazon's involved with, and Apple's involved with.
Fantastic. So now just fun questions to both of you. Personally, Dr. Larson, do you prefer cardio or are you a strength trainer?
I think you have to have a little bit of both. I think especially, and I'll say, so I grew up playing ice hockey, so there was always a balance of both in there. And one of the things I've noticed as I've gotten older, both get harder to maintain, but I think you also have to try and find a good way to balance both. So I probably enjoy the strength training side of it a little bit more, but I recognize that the aerobic part is a necessary complement to it. So I really enjoy the sorts of activities that get you a little bit of both. I bought a rowing ergometer this winter to try and use a little bit more in the basement because I think that's a nice form of exercise that strikes a balance with both.
How about you, Dr. Reddy? Are you a runner?
So believe it or not, the most common type of exercise I do is actually flexibility and stretching, because as you get older, you get up out of bed and every joint hurts, every muscle's tight. And so every morning I do stretching. But it's also a balance. Yeah, when I was younger, I used to do a lot more cardio, but my joints are starting to hurt. I've realized the importance of kind of shock absorption with the muscles around your joints. And so I'm doing a good balance. I try and do, actually every workout I do a little bit of cardio, a little bit of strength training, and then also some flexibility, just to kind of keep it balanced.
Absolutely. I agree with you. I used to be a big treadmill person, and then with several years of wearing lead destroyed my hips, and now I've switched to the Peloton, and now it's Peloton and strength training. That's and flexibility, as you said. After a long case, I'm like, oh my God, I'm frozen in this position. I need to move everything. But thank you both so much for taking time. We are recording on a Saturday, so I really appreciate you both taking time off on a Saturday and joining us and talking to everyone about wearables and VO2 max, a very undermined vital sign almost, and how to use heart rate variability and heart rate recovery in kind of tailoring each one's exercise for a better life. So thank you so much for joining me today.
Thank you.
Thanks for having us.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.